I'm Marlene Hurst, President of Hurst Review Services, and I want to thank everybody for being here today. And what we're going to do this week is this. I'm going to tell you everything you need to know to pass the first time so you can pay for the car you've already got picked out, okay? Okay, that's the plan. Now, let me tell you a little bit about Hurst Review so you'll understand how we're different than other reviews that you may or may not have taken before. First of all, we are not going to read to you for a week. What we are going to do is teach and explain the content so you'll be able to answer those critical thinking and application questions like you're going to have on boards, all right? So be happy that we're not repeating nursing school. Nobody wants to go through nursing school again, right? Right. Another thing that we do that's different is we are going to focus on the core content of NCLEX. Now, when I say the core content, what I mean is the information that you have to know without a doubt and without hesitation if you want to even have a chance of passing boards the first time. So that's the stuff we've got to focus on first. Now, how did I say you had to know that information? I said you had to know it without doubt and without hesitation. You've got to know that material that way. So we are going to focus on that. Now, after saying that, let me say this. Are we going to cover every possible thing that you could see on that test? No, there's no way. I mean, they've probably got 9,000 questions in that computer. So it doesn't matter how many books you have or how many CDs you've memorized questions from. They've got probably 9,000 more questions waiting for you when you get there. So what we're going to teach you to do this week is how to take what you do know, even if you only know this much, and apply it to things that you've never, ever even thought of before. Because on this test, can they make up names of drugs, names of diseases, and diagnostic tests that you've never heard of before? Yes, and that's going to upset you. People don't like that. Nursing students want a handout, don't they? You give me a handout, and I want the test to come off the handout, right? Or you know how you get during the test. People start getting mean during the test if something's on there that didn't come off the handout. Well, we're going to show you how to react to those situations. Now, you've also got to understand how the test works to be successful. So we're going to know our core content, then we're going to know how our test works, but also we're going to master the test questions, all right? Now, the good news about the test questions is this. We do not have to make 100 on this test. We gave up on that a long time ago, didn't we? Yes. That was on the bed-making test that we gave up on trying to make 100. But what we're going to do is we're going to show you how the test is graded. And the test is graded, to put it very simply, you got to get more right than wrong. Now, the first thing that goes through people's mind is this. Well, nursing school wouldn't have been any big deal if all I had to do was get more right than wrong throughout nursing school. But see, in nursing school, you have to make a grade, don't you? Like a 77 or an 80 or an 82, depending on where you went to school. The good news is this. NCLEX is not graded that way. It's looking at how consistently right or consistently wrong you are. And later in the week, I'll show you exactly how the test is graded, because if you don't understand how the test operates, and you can make some bad mistakes that would actually make you be unsuccessful on the test, okay? So we've got to understand how the test works. The other thing I mentioned was the test question. I like for students to master the core content first, then we move on to test taking. Because if you don't understand the core content, you're going to keep on missing the same questions over and over and over again. And I'm going to show you how to answer the questions in a way to make the NCLEX people happy. Because isn't that who we want to make happy? Yes. The NCLEX people are scared of you, okay? They're scared you're going to hurt people. And so I'm going to show you, hey, that's what the test is all about. I bet in school your teachers told you that the test tests minimum competency. Yeah, everybody's heard minimum competency. In other words, the most minimum scary nurse you have to be before they'll turn you loose on the floor to take care of people. The most minimum. Well, that gives people a false reassurance because they think, well, I went to the hardest nursing school. I've already got a job over here in the neuro ICU. Surely I'm minimum, or they wouldn't be letting me work over here. Yes, they would, wouldn't they? Yeah. They'll let people work over there before they pass their test. But I don't want you to get a false reassurance, all right? The test is very hard, and I'm going to show you how to answer the questions to make the NCLEX people happy. And the good news is this. Every single person in here can pass this thing the very first time they take it, okay? If you choose to, because I'm about to lay it out to you exactly like it has to be. Basically, there are 3 different levels of questions on the test. Low, medium, and high. Now tell me something. What level of question do you want to get on the test? Tell me. I heard high. Yay, that's what you want. A lot of people say they want low level. because they're thinking, ooh, I want the low. That's the easy stuff. No, low-level questions are the hardest questions to answer because they are memorized facts that you either heard somewhere along the way, or your teacher put it on the handout with a star by it, or maybe you read it in a shaded box in your book, right, that said NCLEX alert to the side. People love to read the shaded boxes. We just don't like to read all the pages, right? Right. Okay. Well, let me give you some examples of this because you need to understand the different levels of questions. And you're right, we want high level. We do not want low level. But let me give you some examples of low level so you'll see why you don't want them. Now, some of you, maybe all of you, will know the answer to this. Tell the person sitting next to you the name of the ulcer you get in your stomach when you're badly burned. Tell the person sitting next to you the name of the ulcer you get in your stomach when you're badly burned. Okay, just talk and make up something. Anybody want to take a guess at it? Anybody? Stress ulcer. That would be a correct answer, but there's even a more specific answer. Okay? Now, remember, y'all, this is a low-level, easy question. This is why we don't want these, all right? Because if you've heard the answer to this somewhere along the way, great, it stuck with you because it's going to be weird. The name of the ulcer that you get in your stomach when you're badly burned is a Curling's ulcer, okay? And we're going to talk about that in the burn section, which is a type of stress ulcer. But if you're thinking on a higher level, when you're thinking about burns, you're supposed to be thinking about fluid mobilization out of the vascular space in the first 24 hours and the vascular volume coming down and your patient getting very shocky. You aren't sitting around the house thinking about the word Curling's ulcer. Now, are you? How do you take what you know about burns and magically come up with the word Curling's ulcer? You don't, do you? So if you heard of it before somewhere along the way, it was weird and it stuck with you, so you got that one right. But for those of us that had never heard of that, we're mainly guessing, aren't we? And when you're guessing, we usually miss, don't we? Okay, so we don't want to get those questions where we're guessing. We want to get a question where we're having to think for a period of time. Get it out of your brain that a question's going to pop up. You're going to read it. You're going to read all four answers, and bam, you're going to know the answer. There is no question like that on NCLEX. You are going to sit there and you're going to stare at the screen and stare at the screen and stare at the screen, and with every answer you pick, you're going to wonder did I pick the right answer. You know, the reason I say that is in nursing school, sometimes you can answer a question and bam, you just know B's the right answer, don't you? Yeah, it's not going to be that way on NCLEX. And feel okay about that because it's that way for everybody across the United States. Don't just feel like it's you. This is very important for passing boards, y'all. When you're sitting there, when you get something you've never heard of, or you're feeling like I really don't know if any of my answers are right, don't feel like it's just you. It's everybody that feels that way. Okay? Let me give you another example of a low-level question. Are you ready? Tell the person sitting next to you the name of the ulcer you get in your stomach when you have a lot of increased intracranial pressure. Mm-hmm. Tell your friend. Some of you want a new friend, don't you? Even though you just met this friend, we want to trade them in already. Does anybody, well, let me give you 4 options. How about this? We like it better when we have options, don't we? At least we can guess then. All right, is it a Curling's ulcer, a Cushing's ulcer, AD dominant ulcer, or an AD recessive ulcer? Discuss those 4 options with your friend. Cushing's, Curling's, AD dominant, AD recessive. Now, one of the things we're going to do this week is this. We're going to vote. Because I have found that nursing students are scared to say the wrong answer, all right? And I want you to get over feeling like you have to be right all the time. That's not what nursing's all about. That's not what critical thinking's all about, and that's certainly not what NCLEX is all about, okay? So when you vote, I want you to get over feeling inhibited, and I want you to raise your hand proud and be proud of your wrong answer this week, okay? So let's vote. How many of you said Curling's ulcer? Cushing's? AD dominant? AD recessive? Okay. You got the right answer. Cushing's ulcer. I almost said the wrong one. Cushing's ulcer. Cushing's ulcer. Now, I don't know about you, but when I think about Cushing syndrome, the first thing I think about is the person in my book, that picture of that man in my book with the moon face, the buffalo hump, skinny, large abdomen. All right, we don't want to get confused here with that. That's Cushing syndrome. All right? Cushing syndrome. All right, now then, I got to tell you something about those last two answers, AD dominant and AD recessive. I just made those two up. Now, I do that because are they going to make stuff up on NCLEX? Yes, but some people always will pick AD dominant or AD recessive because I have found that a common strategy that nursing students use across the country would be this. They think, okay, I've never heard of that before, and I'm a dumb nursing student, so that must be the right answer, okay? Don't ever use that strategy. Here is a rule I want you to follow. If you've never heard of it, nobody else has either, so do not pick that for an answer. I said if you've never heard of it, nobody else has either. Even if you're not real familiar with it, don't pick it. Because y'all, they already know what you know real well, okay? And they know things that you don't know real well because you're brand new nursing students. And I'm going to talk more about the brand new nursing student issue in just a second. Now then, you see, if you're thinking on a higher level about increased intracranial pressure, you're thinking about doing your neuro checks like you're supposed to do so you can recognize when the neuro checks are changing so you'll know when the ICP is going up. That's what you're supposed to be thinking about. You aren't thinking about a Cushing's ulcer. There's no way to take what you know about ICP and magically come up with the word Cushing's ulcer, okay? Now, let me give you one more example of a low-level question, then we're going to move on from this concept, okay? And I promise everybody in here will know the answer to this. Are you ready? Tell the person sitting next to you how the skin feels when somebody's going into shock. Tell the person sitting next to you. And I bet you just whisper to your friend, cold and clammy. Okay, now here's my point. Everybody across the United States knows that your skin gets cold and clammy when you go into shock. Everybody knows that. Hey, the NCLEX people already know what you know well. So why would they want to waste their time giving you a question on something they know you already know? They know everybody knows that, so they're not going to waste their time on that kind of stuff. All right? So here's a rule. Nothing you know well will ever be on the test, okay? All right, that's just a rule. Nothing you know well will ever be on the test. That's something else that's going to decrease your anxiety. That's because when you go in there, if it's all kind of foreign to you, it's just like that for everybody. And the majority of the people across the country still pass the first time, and you can too. All right? Now, when you sit down at your computer, what's the first question that's going to pop up? Is it going to be a low, a medium, or a high? I heard somebody say medium. That's what it's going to be. First question pops up and it's going to be a medium, but how are you feeling at this point in time? Most people are scared, aren't they? Scared and nervous and upset, and those feelings of being scared and nervous and upset and feeling like you probably hadn't studied enough started the night before, didn't it? So forget what it says in those books about get a good night's rest prior to the exam. Because is anybody going to get a good night's rest prior to the exam? No. Everybody's going to wake up every hour on the hour staring at the digital clock, okay, just like you did the night before clinical. That's just the way it is. You'll be okay. You'll have enough epi and norepi going that you'll be fine during the test. You will be exhausted when you leave, though, okay? So first question pops up, and it's supposed to be a medium-level question, you're thinking. Y'all, it doesn't matter what the first question says. The first question can say, is your patient supposed to have a pulse? And you know what you're going to say? I can't believe that's on here. What's that? It wasn't on my handout. You see, the more nervous people are, the more foreign everything sounds to them. But at some point, you will get in a groove, I promise. You'll get in a groove and things will start, you'll be able to recognize things, is what I'm saying, as time goes on. So, okay, so we may miss the first one. So what? If you're going to miss some throughout the test, again, we're not trying to make 100. If you get a medium level question right, you're either going to get another medium or it's going to go a little bit Higher. I'm going to teach you this week how to study in a way where you either stay in the medium or go into the higher, but we must stay out of the low, because when we get into the low level, we're usually missing those, aren't we? Okay, and we don't want that. So we're going to study in a way to get us into the medium and the high. Now, the higher the level of question, how do you feel? Worse. I always say this, the worse you feel when you come out, the better you did. That's just the way it is. Because when you start getting into high-level questions, you don't have a clue what's going on. All 4 answers are looking good to you at that point, okay? Now, when all 4 answers look good to you, that means you either hadn't studied or you're in the high-level questions, okay? And after having taken this course, we know you will have studied, okay? Now, as you've already can tell, one of the things that we do in here is we make you talk to each other. I think that is so important that we get students to talk to each other. I don't like it when teachers just lecture at people all week, because you're just a passive recipient like that. We've got to get you involved, because from doing this class, I know this. If you can say it, you can pass it. If you can say it, you can pass it. If you can't say it, you're going to be unsuccessful. So I don't want to be the only one that can verbalize information. I want to get you to talking to each other too. And before you take your test, you will have verbalized this whole packet at home by yourself, locked up in a room. Okay? Because that's the key. If you glance down at your notes and hold your head up and nothing comes to mind, then we know we need to study some more, right? So we're going to teach you how to verbalize and interact with each other. That's very, very, very important. It's being able to talk to each other. All right. So that's your 3 different levels of questions you can get. Throughout the week, we're going to take plenty of breaks. All right. Plenty of breaks, and the video review people, be sure and follow the order in which that we have your handout, just like everybody else. It's very important that you take the breaks and don't try to go all the way through the packet without taking breaks. That's not good for anybody, okay? So stay in the order in which we've got outlined for you. All right. Go ahead and turn to fluid volume excess for me. Fluid volume excess. We're going to start with your favorite subject this morning, fluids and electrolytes. We'll start each morning with a favorite subject, okay? Every morning we'll start with the favorite subject. So, fluid volume excess, that's the nursing diagnosis, okay? And y'all all, first day of nursing school, probably got that little card where they listed all the nursing diagnoses on it for you. It came with your Tabor's Medical Dictionary usually, okay? All right, the other term for that is hypervolemia. Now, let's talk about it. It says on your handout, too much volume in the what? What is hypervolemia? Too much volume where? Vascular space. It's too much volume in the vascular space. Now, when I say vascular space, what am I talking about? What is a vascular space? What's a vascular space, y'all? It's any vessel in your body. Any vessel in your body, whether that's a vein, an artery, capillary, whatever. It's any vessel in your body. So when you've got somebody that's going into a fluid volume excess, all of their vessels are filling. Now, some people think that fluid volume excess is when you have too much fluid out in your tissue, interstitial space. No. When somebody is going into fluid volume excess, we always fill the vascular space up first. Then we leak out into the tissue. That's when you'll see edema, okay? Now, also, when I say fluid volume excess, I'm not just talking about the vascular space getting too full. Am I also including the chambers of the heart here? Yes, the chambers of the heart are filling up too. So I want you to envision that the chambers of the heart, the inside of the heart is filling up with fluid, and all your vessels are filling with fluid. All right, now, on your handout, I have several different causes listed there. It will take you about a page of taking notes with me to get used to how I lecture, okay? So just hang with me for a page and fill in the blanks, and you'll be fine. Now, in congestive heart failure, is your heart weak or strong? Weak. So your cardiac output is going to go up or down? Down, that's right. So you have decreased kidney perfusion. And anytime you have decreased kidney perfusion, the urine output is going to go up or down? Down. All right. The volume stays in the vascular space. Now, we've got to recap this, and I want you to talk to me now. Everybody look at me. Okay? When you're in heart failure, is your heart weak or strong? Weak. So cardiac output just went down. So kidney perfusion just went down. And anytime you aren't perfusing your kidneys, your urine output's going to go down. If you aren't putting out fluid like you used to, where is all the fluid going to accumulate? In the vascular space, and that's what it says on your handout. Okay, so you've got to get to where you can talk out information, all right? Now, renal failure, that's an easy one. Your kidneys aren't working. Kidneys aren't working. And if your kidneys aren't working, are you putting out anything? No. So where is all the fluid going to build up? In the vascular space. In the vascular space once again. Now, the next three go together. Alka-Seltzer, Fleet Cinemas, and IV fluids with sodium, because all three of those have a lot of what? Sodium. And sodium has a tendency to make you retain water. But where are we retaining that water or fluid? In the vascular space once again. You see how many times we're saying vascular space? Yes. All right, now aldosterone. First of all, is aldosterone a normal chemical to have in your body? Yes, it's a normal chemical. It is a steroid, and if you want to get real picky about it, it's a mineralocorticoid. And I think we talk about aldosterone just about every single day in this class, all right? So we might as well just go ahead and understand the normal action. But before we get into that, where does aldosterone live? Adrenal glands. Aldosterone lives in our adrenal glands. All right. It's very important that anytime we have a chemical that we go over the normal action of the chemical first. So let's understand the normal action of aldosterone. Here we go. When blood volume gets low, and as you know, lots of things can affect your blood volume, right? Like vomiting or losing blood. Blood volume's gotten too low. Aldosterone secretion increases, which makes us retain what? Sodium in water, so our blood volume increases. Now, y'all, is this a good thing or a bad thing that's happening? If you've lost a lot of blood, do you want to retain sodium in water? Yeah, because you want to replenish your vascular volume, don't you? Yes. Now, let me point out something. So this is a normal mechanism we have in our body. It's a good thing, okay? Now, one thing I want to emphasize here is this. If you want to get aldosterone questions right, you'll always say sodium in water, okay? If you want to get aldosterone questions right, you will say sodium in water. You will not say fluid, and you won't just say water. And you'll see why that could affect your answer here shortly, okay? Now, diseases with too much aldosterone. All right, now it says on your handout that too much aldosterone can be seen with liver disease and heart disease. But also, y'all, there are two more diseases where the body is making too much aldosterone. Tell the person sitting next to you the name of the diseases that you can get if you're making too much aldosterone. Discuss that for a second. Remember, it's a steroid. The first thing most people say to each other is Cushing's. Yeah, Cushing's syndrome. Now, Cushing's syndrome is when you have too many of all of your steroids, okay? Not just aldosterone. But aldosterone is a steroid, so with Cushing's it would be applicable. Now, there's another one where you're making too much aldosterone. Anybody know what it is? Okay, I'll tell you. Are you ready? Hyperaldosteronism. 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 But it's also known as CONS. C-O-N-N apostrophe S. CONS. C-O-N-N apostrophe S. All right. If my body, everybody just listen to me for a second. If my body is making way too much aldosterone, what am I going to retain too much of? Sodium in water. Where am I retaining that sodium in water? In the vascular space. So I'm going to go into a fluid volume excess. All right. Now, could one day my body stop making enough aldosterone? Sure. That's the deal with chemicals, y'all. You can either have too much or not enough, too little, okay? Tell the person sitting next to you, how the vascular space is going to be affected if we are not making enough aldosterone. Discuss that. Let me ask you something. If you do not have enough aldosterone, are you going to retain sodium in water? You can't retain it because you don't have enough aldosterone. So you're going to lose sodium in water and go into a fluid volume deficit. There you go. Going to go into a fluid volume deficit because we're losing sodium in water. Now, what's the name of the disease where you're not making enough aldosterone? Addison's disease. That's it. That's your Addison's disease. Addison's disease. All right, the next chemical we're going to talk about is ADH. ADH. Now, normally, does ADH make you retain or diurese? Make up your mind. I heard both answers. Retain what? Water is the key. ADH, retain water. Notice I did not say sodium in water, did I? I said just water. That, to get ADH questions right, you must think water only. That's the key. Now, the normal action is to make you retain water because it's an anti-diuretic, right? Now, when you are retaining that water, where are we retaining that water? In the vascular space again. Now, just like any other chemical, you can have too much or too little. Since we're on the fluid volume excess section, let's go through the too much column first, okay? So, my body's making too much ADH. I'm going to retain too much what? Water. Where am I retaining that water? Vascular space. So my patient goes into a fluid volume excess. Fluid volume excess. And the name of this disease is SIADH, Syndrome of Inappropriate ADH Secretion. That's why we just say SIADH, okay? Now then, let's just talk a little bit before we move on down the page. There's a couple of things I want to get straight with you. Now, one concept that y'all went over in school is this. The blood and the urine normally mirror each other. And when I say mirror each other, I mean normally the blood and the urine look alike. Now, what do you mean by that, Marlene? Well, I mean this. If you drink a lot of water, your bloodstream is going to become more dilute, and the urine you put out is going to be more dilute, isn't it? It's just like if I go a week without fluids, my blood's going to be more concentrated and the urine's going to be more concentrated. If you've got somebody who's a diabetic, their bloodstream is full of sugar, and your teacher told you that the excess sugar would spill over into the urine, so now you have glucosuria too. So see, normally the blood and the urine look alike. Well, we're going to mess it up here, all right? This is what makes SIADH different than other diseases. As you can see on your handout, I've got urine and blood. One's going to be concentrated, one's going to be dilute. You and your friend figure out which one's which. Come on. Urine, concentrated, blood, dilute. Urine, concentrated, blood, dilute. Well, that's weird, Marlene, because you just got through saying that they looked alike, and now they're opposite of each other. Well, let's understand why they are opposite of each other. Because if you are making too much ADH, you're retaining too much what? Water. Where are you retaining that water? In the vascular space. So that's making my blood very dilute. Okay? Now let me just say this before we move on. Normally, if you drink 10 bottles of water in an hour, your kidneys want to help you do what? Excrete the excess. So do you agree that normally When people are in a fluid volume excess, urine output goes up. Yeah, that's normally what's supposed to happen when you're in a fluid volume excess. If your kidneys are working properly, urine output goes up. Now, is the urine output going up in SIADH? Ask your friend. What's the urine output doing here? Decreasing. See, this is weird. That's why we're talking about it. You've got somebody in a fluid volume excess and their urine output is actually decreasing because they're making too much what? Talk to me. ADH, which is forcing them to hold on to all of their water. Forcing them to hold on to all of their water. Okay? Now, does this process I just talked about make the fluid volume excess better or worse? Worse, because the patient's not able to excrete the excess. So it's making their fluid volume excess even worse because they can't excrete any fluid. So this is why the urine and the blood look differently. Here is one time for sure that you've got somebody in a fluid volume excess and their urine output is going down. Now also let me make clear, what little urine they're putting out, is it going to be concentrated or dilute? Concentrated. Yes, it's concentrated. You see, your kidneys will try to put out a little bit just to stay alive. So what little is coming out is going to be concentrated. Notice it says on your handout, concentrated makes numbers go up, dilute makes numbers go down. That's a very important concept. The two numbers I'm talking about, though, are the specific gravity and the sodium. No other numbers. Don't say potassium or anything like that. Specific gravity or sodium. So this is what they'll do to you on NCLEX. They'll say, you've got somebody in SIADH. Tell the person sitting next to you what's going to happen to their serum sodium. Discuss that. Well, if the blood is dilute, the serum sodium is going to go down because dilute makes numbers go down. Okay? Now then, before we move on, look over to the right and let's go down the not enough column. If you do not have enough ADH, can you retain water? No. You're going to lose water. You're going to diurese. So you've got a patient here that is going into a fluid volume deficit. Could they go into shock? Yes, this is my number one concern, that they're going into shock. Now let me just ask you a question. This isn't on your handout. I just want to ask you a general question. Let's pretend you've got somebody that's in surgery and they're hemorrhaging. So they're going into shock, right? Normally when people are getting shocky, how will the urine output respond? With normal plano shock, urine output goes down to help the patient what? Yeah, increase volume, hold on to what little they have left, compensate. We've got somebody here that's going into shock. Now tell your friend how their urine output is affected. Is their urine output decreasing like it's supposed to? No, it's increasing. You've got somebody in shock and they are still putting out large amounts of dilute urine. Still putting out large amounts of dilute urine. Could this kill them? Yes. It could kill them because they can go into vascular collapse, can't they? Yeah, we've got to interrupt this process by giving the patient some ADH. Giving them some kind of form of ADH so they can hold on to water like they're supposed to. And at the bottom of the page there I have some examples of some ADH drugs you can give. All right, also on your handout, once again, I've got urine and blood. One's going to be concentrated and one's going to be dilute. You and your friend figure out which one's which. Urine, dilute, blood, concentrated. So if I asked you on NCLEX, what's the urine specific gravity going to be like? What would you tell your friend? High or low? It's going to be low because dilute makes numbers go down. And some of you may be saying, well, what's a normal urine specific gravity? I don't know, okay? You don't have to know. You would just pick the number that is the lowest on there, okay? And on the CD that you're going to get on the last day, we've got all kind of normal lab values listed for you, okay? So we'll worry about numbers later. Now, ADH lives in the pituitary. Point to your pituitary. Yeah, it's right there, okay? Some of y'all are pointing other places, all right? It's right here. All right, now then, key words to make you think potential ADH problems are craniotomy, head injury, sinus surgery, or the dreaded transsphenoidal hypophysectomy. Now, why do I give you that little scenario there where I say key words to make you think potential ADH problems? Well, how many times have you heard your friends say, I have got to go get my ADH checked? Never, have you? You've never heard anybody say that? People don't even know they have ADH. Well, you may be taking care of somebody in the hospital one day with a head injury, pituitary tumor, craniotomy, sinus surgery. Hey, anytime something gets too close to the pituitary, could the pituitary get disturbed? Yeah, and you never know which one people are going to get. Some people get SI, some people get DI. You never, ever, ever know which one people are going to get, okay? So you have to be looking for ADH problems. Even though they're in there for a head injury or a stroke or something like that, you have to always in the background be thinking about a potential ADH problem could develop. If you ever get a question where there's a head thing going on, and then they give you urine output in the question, I guarantee it's an ADH question, okay? Now, take a second, please, and break down the words transsphenoidal hypophysectomy with your friend, and then we'll talk about it a little bit. Try to figure out what those words mean. Trans means you're going all the way through something, okay? And, you know, what I always relate that back to is when I was studying a transmural MI, I can remember my teacher saying that trans meant it went all the way through the muscle, okay? Transsphenoidal. What's a sphenoid? It's a sinus, something up here, right? I memorized that in A&P. Remember when we had to memorize all the bones for A&P? Okay, it's something up here. It's a sinus, isn't it? Hypophysis is the fancy word for pituitary. You've got your anterior hypophysis and your posterior hypophysis. Ectomy, something's coming out, right? Yes. So for those of you that have been taught about a transsphenoidal hypophysectomy, great. You didn't have to go to all that trouble. For those of us who haven't been taught about that, we've got to learn how to break down words and look for something we do know something about. Ectomy may be the only thing I know what it means, okay? Now, with a transsphenoidal hypophysectomy, that's when they're going through your nose to work on your pituitary. So, could my pituitary get upset? Of course. All right. Now, before we move on, I want you to go back up to the words diabetes insipidus. Diabetes insipidus. I want you to circle the D in DI, and I want you to move up and circle the D in diuresis. And from this point forward, anytime you hear the words diabetes insipidus, I want you to think diuresis first, and you'll get more questions right than wrong. Okay? Does this type of diabetes have anything to do with your blood sugar at all? No, so we're not going to pick a blood sugar answer here. Okay? This is a shock question. All right, let's move on the next page and look at our signs and symptoms now. Now, I want you to focus on fluid volume excess with these signs and symptoms. Fluid volume excess. We have distended net veins and peripheral veins because the vessels are full of fluid, right? Yes. Think about somebody that's 9 months pregnant. When you're 9 months pregnant, you're in a fluid volume excess, right? And the patient always has really nice hand veins. That's why they always let the student nurses start all the IVs in labor and delivery, right? Because you can't miss. You don't even need a tourniquet to start the IVs. The vessels are so big. Peripheral edema and third spacing can occur because the vessels can't hold anymore, so they start to leak. Yes, they're leaking now. Peripheral edema may be like ankle edema, but if you've got somebody who's been on bed rest for a period of time, are they going to have ankle edema? No. Where will they have edema? Sacrum. Sacral area. And anytime you've got edema in the tissue, especially back here, what is that skin about to start doing? Breaking down. So you've really got to keep them off their back and make sure you're doing really good skin care. All right, and we're going to talk more about third spacing in just a little bit. Now, CVP. Where is CVP measured? In what part of the heart? Right atrium. Right atrium. And if that right atrium is full of fluid, the number is going to go up. The number goes up because of the next sentence. More volume, more pressure. More volume, more pressure. That's making the number go up. Now, if you're in a fluid volume excess, what are your lung sounds going to sound like? Adventitious, crackles, wet, whatever you want to say. Now, when somebody is first going into fluid volume excess, where are you going to hear those adventitious sounds first? Up high or low? Low in the bases. In the bases. Now, when you're doing, if you want to do a good lung assessment, you'll always listen posteriorly for sure. Okay? A lot of times when you are doing a lung assessment, you'll see nurses come in and they only listen in the front, anteriorly. You're not doing a good lung assessment like that. Okay? All right, polyuria, because the kidneys are trying to help you do what? Diurese. Excrete the excess. Diurese. Now, we're assuming here that our kidneys are working properly, right? Okay. What's my pulse going to do in fluid volume excess? Is my pulse going to go up or down? Up. Pulse goes up. Now, look at the next statement. It says, your heart only wants fluid to go forward is the magic word. We only want forward flow in the heart. Everybody knows that. That's why we have valves inside our heart to prevent that flow, right? Okay, so we want it to go forward because of the next sentence. If the fluid doesn't go forward, it's going to go backwards into the lungs. Now I'm in pulmonary edema. That's what we didn't want to happen. So that pulse is going to go up to try to pump that fluid forward. So it's pumping harder and faster, moving the fluid forward, trying to keep it out of the lungs. All right, blood pressure. What's my blood pressure going to do? Up or down? Up. More volume, more pressure. That's right. More volume, more pressure. We're going to say that little phrase a lot this week. Okay? Now, what is going to happen to my weight in fluid volume excess? Up or down? Up. Any acute gain or loss isn't fat, it's fluid. Now, when I say acute, what do I mean? Overnight, fast gain, okay? So that's why we do daily weights on people. We weigh them every day, and if overnight they've gained a lot of weight, we know that is fluid, fluid, fluid. And anytime somebody's retaining too much fluid, we have to worry about heart problems first, don't we? Yes, heart problems first with fluid retention. Now, another point I want to make before we move on is this. On your test, you could get a lot of questions where you're having to teach somebody. Teaching questions, okay? Well, you may be teaching the patient. You may be teaching another nurse. You may be teaching a family member. As long as you know your content, you will be able to answer teaching questions. So don't get upset if you get a lot of questions where they're making you teach somebody. Teaching is one of the most important things we do in nursing. And if you go 30 minutes without teaching somebody something in the hospital, you're not doing everything you're supposed to do. Okay? Now, I want you to teach the person sitting next to you everything you know about daily weights. You all learned this the first week of nursing school. Teach your friend about daily weights. And I bet your friend said same time, same scales, same clothes. Have the patient void first. But what if it said on NCLEX, same nurse? Would this be appropriate or inappropriate? Remember, this is NCLEX. Ask your friend. What you think? Appropriate or inappropriate? Hey, what if it's your day off? You're not going to come in and weigh somebody. If it were true, but see, they can make anything sound good on NCLEX, can't they? Yeah, reasonable, like, oh yeah, same nurse, write that down. No. We've got to learn how to recognize information like that. What if it's your day off? You're not going to come in and weigh somebody. If that were the case, that the same nurse had to do the daily weight every time, then nobody would ever start doing the daily weights, would they? That's right. That's why we document those other things, the scales, the time, the clothes, all that sort of thing. So when it is your day off, the next nurse can pick up on it, okay, and do what they're supposed to do. Now let's look at our treatment here for fluid volume excess. First of all, low sodium diet. Well, that makes sense, because if they take in too much sodium, they're going to retain more fluid, water, so we don't want that to happen. So low sodium diet. Diuretics can be used to get rid of fluid, right? Get rid of fluid, such as a loop diuretic. Now, besides Bumex that you see listed out to the side, give me an example of a loop diuretic. Lasix is the first one we think of. Lasix. And it also says on your handout that Bumex may be given when Lasix doesn't work, okay? Now, when you've got somebody on Lasix or your hydrochlorothiazide that's listed underneath, what electrolyte do you have to worry about losing? Potassium. I'm worried about hypokalemia. Worried about hypokalemia. All right. Now, give me an example of a potassium-sparing diuretic. Aldactone. Aldactone. And I know you would never say aldosterone there, now would you? No, we wouldn't do that. Now let me ask you a question. When somebody is on aldactone, are they diuresing? Yes or no? Yeah, because it's listed under diuretics, isn't it? Yes. But for a split second, you thought it might not, right? So you're diuresing, but not losing what? Potassium. This person's holding on to potassium. Holding on to potassium. So here, I'm worried about hyperkalemia. Hyperkalemia. You see how I keep using the word worried? That's one of the strategies I use for teaching about NCLEX, is always finding out what you're supposed to be worried about, okay? You're going to hear me say that word a lot this week. You see, y'all, with some diuretics, you need to encourage potassium foods. With other diuretics, you need to limit potassium foods. And as we all know, banana will never be an answer, right? Right, because that's the only potassium food we all know for sure, all right? So it'll never be on the test. Now, bed rest is good for the fluid volume excess person because bed rest induces diuresis. Bed rest induces diuresis because it says on your handout, when you are supine, you perfuse your kidneys more. When you're supine, you perfuse your kidneys more, so therefore urine output is going to go up. That's why in the first semester of nursing school, they taught you that scary lecture, the hazards of immobility. Do y'all remember that scary lecture? Well, the reason people get many of the hazards of immobility is because of the diuretic effect that we get when somebody's on bed rest. When you're diuresing a lot, your blood becomes thicker and more dehydrated, so you're more prone to a clot, a DVT, or you're more prone to kidney stones. Your pulmonary secretions become thicker because you've lost water, so the patient's now at risk for pneumonia. Bowel secretions become thicker because you've lost so much water, so the patient's now at risk for constipation. So there's a lot of hazards of immobility besides just developing decubitus ulcers, all right? So my point is this. If you've got somebody on bed rest, as long as it's not contraindicated, every time you go in the room, encourage them to drink fluid and teach them the importance of drinking fluids while they're on bed rest. Okay? Now, interventions. Physical assessment. From this point forward, anytime you see the words assessment or evaluation, I want you to think signs and symptoms. Assessment or evaluation, I want you to think signs and symptoms. And we've already gone over several signs and symptoms there. Now, in nursing school, they give you that big fat clinical packet, don't they? And they want you to go into that patient's room and do a biopsychosocial, spiritual, cultural history and assess the family and community while you're in there too, right? We don't have time for that anymore. I want you to learn the pertinent signs and symptoms, okay? Now, here's my scenario. Let's pretend we've got somebody that's in a fluid volume excess, and the doctor has ordered 40 Lasix IV push each AM, low sodium diet, and bed rest. If the plan of care is successful, tell your friend how all of these symptoms that I have listed on your handout will change. Discuss it. Come on. All right, y'all. I said if the plan of care is successful, the blood pressure's going to go down. Pulse, down. CVP, down. Weight, lungs. You wanted to say down, didn't you? You never want the lungs down, okay? You want them clear, all right? But it sounded reasonable for a split second. We want them clear. So you see, when you're looking at test questions, you've got to look at, what phase are they in? Is it before treatment? Is it after treatment? If it's after treatment, was the plan of care successful or not? Pertinent signs and symptoms are very important on this test. I said pertinent because I know sometimes when you've been reading about a disease, they've given you a weird symptom like enlarged tongue, right? And you're thinking, where do they get the enlarged tongue from? You don't have to worry about that kind of stuff. We're looking for the pertinent symptoms, okay? Y'all, the NCLEX people think of you as a brand new nurse with 2 weeks of vast nursing knowledge. It's very important that you understand how the NCLEX people think of you. They think of you as having how many weeks of vast nursing knowledge? 2 weeks. So can you know everything? No, they don't expect somebody with 2 weeks out of school to know everything. Okay? They don't know that some of you are already paramedics or LPNs. They don't know and they don't care. All right? So we've got to get you to thinking like a brand new nurse, and that's what we're going to do this week. Also, it says on your handout to give IV fluids slowly to elderly. Because can you throw the elderly people into overload fast? Yes, you've got to be very careful with not only the very old, but also the very young. All right. We'll do one more page and then we'll take a break. Fluid volume deficit, also known as hypovolemia. If you're in a big-time deficit, we're going to call that shock. Now, y'all, there's degrees of shock, okay? Lots of different degrees of shock. You can have a little bitty case of it, or you can have a full-blown case of it where you're unconscious. Everybody in here has been a little bit hypovolemic at some point in their life because everybody in here has had the 24-hour bug where you had vomiting or diarrhea, okay? Now, let's look at our causes. Loss of fluids from anywhere. Here's the deal, y'all. You lose fluid from your body long enough, and I don't care where it's coming from, you lose fluid from your body long enough and you're eventually going to go into a fluid volume deficit. Okay? Now, on your handout, I have some ways that we lose fluid. Well, thoracentesis and paracentesis. With those procedures, is the doctor pulling off fluid? Yes, so the patient could get shocky during the procedure. Vomiting, diarrhea, well, you're losing fluid. And the one we all understand the most, hemorrhage. With hemorrhage, you're losing fluid directly out of the vascular space. So naturally, you're going to become hypovolemic. Now, another way that you can become hypovolemic is with third spacing. Here's my definition of third spacing, and you will not find this definition in any dictionary. This is Marlene's definition. It's when fluid is in a place that does you no good, Y'all, where have we all agreed that we like for our fluid to be? In the vascular space. Well, if it's third spaced, it's not there anymore. Like if you're burned. When you're badly burned, does your fluid stay in the vascular space? No, where does it go? Out into the tissue or out of the body altogether, right? It left the vascular space. Or if you have ascites. If you have ascites, where has your fluid gone to? Yes, from the vascular space into the abdomen or peritoneum, right? Now, ascites can be weird, though, because when you look at somebody with ascites and they've got a large abdomen, they look like they're in a fluid volume excess, but is the fluid in the right place? Where did that fluid come from? It came from the vascular space. It doesn't just magically appear. So your teacher's got you doing the abdominal girth thing every day, right? Okay, so you're measuring the abdominal girth, and the bigger I get here, my vascular volume could be coming down. So I might already be hypotensive at this point, even though I look like I'm in a fluid volume excess. Another thing about ascites that you have to remember is this. The bigger I get here, it pushes up on my diaphragm, and now I have trouble breathing. Anytime you have someone with ascites, you must remember their breathing problems. They can't stand when you lower their head too much. They can't lie flat. They can't breathe like that. Now, what's a disease y'all have all studied many times, or one of the major signs and symptoms is polyuria? Anybody know? Yeah, diabetes. Diabetes. And this is the only picture I can draw. This is the vascular space, okay? This is the vascular space. Okay, I can draw a cell too. But anyway, this is your vascular space. And if you're a diabetic, what is your vascular space full of? Sugar particles. Look at all the particles. The particle to water ratio is messed up, and your body does not like this. Your body likes for the particle to water ratio to stay the same all the time. Well, if you're a diabetic, you've got too many particles. Now, what I'm about to talk about is true for any particle, okay? But since we're talking about a diabetic, I'm talking about a sugar particle here. Anytime you get too many particles in your bloodstream, you're going to get something called PID. And I don't mean pelvic inflammatory disease, okay? I mean particle-induced diuresis. Particle-induced diuresis. Now think about what those words mean, y'all. Particle-induced diuresis. What are your kidneys trying to help you do? Remember what we said earlier? When your blood sugar's too high, the excess will spill over into the urine, because what are your kidneys trying to help you do? Yeah, get rid of the sugar particle. Your kidneys are trying to help. But y'all, let me ask you a question. Have you ever just excreted a sugar particle one day? No. You would have remembered that day, wouldn't you? Yes. Anytime you lose a sugar particle, you're losing volume with it. Anytime you lose a sugar particle, you're losing volume with it. So the deal is this. In the process of trying to get rid of the sugar particles, are we losing volume? Yes. Polyuria equals shock. Write that down. Polyuria equals shock. So you first have to understand why the diabetic got polyuria, and then you've got to understand how that polyuria affects the vascular space. That's why when you're working in the ER or ICU and you're taking care of people who just have come in with diabetic ketoacidosis, they're always shocky to start with because of the PID. Now sometimes this PID is called osmotic diuresis. I just like the word PID better, okay? That makes better sense to me than the word osmotic. Now, y'all, let me ask you a question. When you've got somebody that's going into shock, who are the first organs to die? Kidneys. It only takes 20 minutes of poor perfusion for acute tubular necrosis to occur. I said it only takes 20 minutes of poor perfusion for acute tubular necrosis to occur inside the kidney. So when you have somebody on NCLEX with a decreased output, do we take it very seriously? Yeah. When kidney stuff starts happening, it starts happening fast. You don't wait around on it, okay? Well, think about how the kidneys must be feeling now. The kidneys were trying to help you get rid of the sugar particles, right? But in the process of doing so, the volume went down, and you just told me that the first organs to die in shock are the kidneys. So the kidneys are ticked off now, aren't they? What were they saying? The kidneys are saying, look, I was trying to help you. I was trying to help you get rid of those sugar particles, and now look what you've done to me. You tried to kill me. So, are the kidneys going to keep on having the polyuria? No, because your kidneys aren't dumb. They're going to switch from polyuria to oliguria, and it could go all the way to anuria, because they're trying to compensate and conserve now. But once again, anytime I've got somebody that's oliguric and anuric, could my kidneys die? Yeah, I'm worried about renal failure again. So, y'all, here's my point. This is the normal sequence of events that will occur when somebody's a diabetic. They start out polyuric because they're trying to get rid of sugar, but they end up anuric, okay? Now let's look at our signs and symptoms here. First of all, if you're hypovolemic, what's your weight going to do? Up or down? Down. Decreased skin turgor, dry mucous membranes. Decreased urine output because the kidneys either aren't being perfused or they're trying to do what? Compensate. Conserve. If you're in shock, what's your blood pressure going to do? Decrease because of our little phrase, less volume, less pressure. That's right. Less volume, less pressure. What is my pulse going to do in shock? Up or down? Increased. It's still up. Because the heart is trying to pump what little you have left around. It's trying to compensate. Now, let me ask you a question. When you are palpating a pulse, are you palpating a vein or an artery? Artery. Because veins don't pulsate, do they? They just sit there. So you're palpating an artery. Now tell me something. What does a shocky pulse feel like? Weak and thready. Weak and thready. Now explain to the person sitting next to you what a thready pulse feels like. Come on. You said it was thready. Now what does it feel like? Okay. When you're in shock, do you have much volume in your vascular space? No. So the size of your artery is what? Very small. Tiny, like a thread. And you all learned in your physical assessment class that the pads of your fingers were the most sensitive area of your hand, right? So when you're palpating the pulse, it feels like a thread tapping on your finger, hence the name thready, okay? Now we all know what it means. Thready pulse. CVP, what is that number going to do? Up or down? Down. Less volume, less pressure. What are my peripheral veins and neck veins going to be like? Very small, teeny tiny. Is it easy to start an IV on this person? No. They may have to have a central line. Cool extremities. Remember we already said cold and clammy earlier today, didn't we? But why do they get cold and clammy? Peripheral what? Vasoconstriction. In an effort to shunt blood to vital organs. In an effort to shunt blood to vital organs. Y'all, I don't know if you've noticed yet, but I really focus on knowing why about as many things as possible. Whether I'm talking about a cause, a symptom, or nursing intervention, you must understand the why part, because it's the why part that makes you pass boards. It's the why part that makes you have the ability to answer those critical thinking and application questions. So that's why we're going to know as many whys as we possibly can in here. Urine specific gravity, is it going to increase or decrease? Increase, because if they're putting out any urine at all, it will be concentrated, and concentrated makes numbers go up. Treatment and nursing interventions. If it's a mild deficit, PO fluids. If it's a severe deficit, IV fluids. And I've got just a short little section on the next page on IV fluids. Let's do that. Quickie IV fluid lecture. All right, first of all, we have isotonic solutions. Here's how they work. They go into the vascular space and they stay there. That's how they work. Hey, an isotonic solution goes wherever you put it, and it's going to stay there and build up and build up and build up. If you're putting it into my vascular space, the volume in my vascular space is really going to build up, isn't it? It make my volume go up, and therefore make my blood pressure come back up again. Hey, you give me isotonic solution long enough, and could you throw me into overload? Yeah, if you're giving it fast, you better be careful with it, okay? Now, examples of isotonic solutions would be like normal saline, LR, lactated ringers, and D5W. That's some examples there. Now let me just talk a little bit more about isotonic before we go on. You and I are isotonic. Don't you have fluid in your brain cells right now? Yes, and isn't that fluid staying where it's supposed to? Is your blood staying in your vascular space? Yeah. Your cerebrospinal fluid is staying just where it's supposed to, because we are all what? Isotonic. If we weren't isotonic, my spinal fluid would be down here in my pancreas, you see. And that's not good. My blood would be leaking out. That's bad. We're isotonic. If I told you to go get a bag of normal saline, what number would be on the bag? 0.9. So when you're giving somebody normal saline, you're giving them 0.9 solution. Now, y'all, if I could put a number on your body fluid, what would your number be? 0.9. You and I are 0.9. So, see, as long as I'm putting 0.9 in here and I'm 0.9, everything is equal. That is why, as long as everything is equal, you don't get a switching and swapping of fluid in and out of the vascular space. Does that make sense? Because everything's equal. That's why isotonic solutions go where you put them and stay there. Now just listen to me for a second. If you want to get a switching and swapping of fluid in or out of the vascular space, you've got to put something in your vascular space that is different than me. And I am what? I'm 0.9. That's why they have hypotonic solutions and hypertonic solutions, because you've got to have other solutions that are different than your own body fluid. Now let's look at hypotonic solutions. They go in the vascular space and hang out a little while and rehydrate. But they do not stay in the vascular space, because if they stayed in the vascular space, they wouldn't be hypotonic, they would be isotonic. So here we go again. These solutions go in and hang out and rehydrate, and then they move into the cell, and the cell burns the remainder up in cellular metabolism. They are hydrating solutions, but they won't drive your pressure up because they do not stay in the vascular space. Do you understand that? They won't drive your pressure up. They hydrate, but they won't drive your pressure up, because is the fluid staying in the vascular space? No. Okay, not for long anyway. Okay, not long enough to drive your pressure up. And on your handout, I have listed hypertonic solutions and hypotonic solutions as well. You see, y'all, you're going to see as we go through this course that not only do we have to know our job as the nurse, we have to know the doctor's job too. Because could a doctor write an order for an IV fluid that was inappropriate for our patient? Yeah, and you're going to see as we go through this course that just because an order's an order doesn't mean we're going to do it. Okay? In fact, that's one of the things they're scared of on NCLEX. They're afraid that because you are a brand new nurse with 2 weeks of advanced nursing knowledge that you're going to implement an order because a doctor wrote it. Well, that's not necessarily true, and the doctor wants us to use our judgment. If they've made a mistake and ordered a normal saline for somebody that's already got high blood pressure, do they want us to go and start that? No, they want us to always look at orders cautiously, okay? All right, let's take a break.